So we're doing the combination therapy of hydroxychloroquine and azithromycin. It's not fully understood how or even if it works, but the initial research is suggesting that it slows down the viral replication. So that would help slow down the process and interrupt the transmission as well. The medication, actually, there's three names that you'll hear it under. So Plaquenil is the malaria drug. It's the brand name. It's used for lupus as well, autoimmune conditions. The generic for Plaquenil is hydroxychloroquine and also sometimes chloroquine, a similar compound. We're only using hydroxychloroquine, the generic and the safer of the two versus the chloroquine. And the other medication is a common antibiotic, Z-pak. It's azithromycin that's used in combination. We have very strict criteria for when we do prescribe it. So we don't prescribe it for patients that are looking to just stock up on it. We don't prescribe it for patients that are wanting to use it preventatively. We're only prescribing it for patients that have a known positive test. So they've been tested, they tested positive, and so those patients are appropriate. So as far as your question about the shortages, we're not prescribing it liberally. We're prescribing it only for patients that really need it. We're trying to prescribe it very responsibly. We require they have a documented positive test result, and that's the strictest standard. We're also, and I think this is something that might have been missed, what happened when President Trump started talking about this is physicians all over the country started prescribing it locally for their patients. And when those patients go to fill that prescription, they're going to go to a local retail pharmacy. And those pharmacies, have a predictable stock for their autoimmune patients, which is year over year very much the same. So that very quickly gets depleted. When we write a prescription for the medication, we don't send it to a local pharmacy because we don't want to interrupt that supply chain. We're using a mail order pharmacy, wholesale pharmacy that will ship it directly to the patient. So we're trying not to interrupt those local sources for the autoimmune patients. And if there are patients that have lupus that are running low, we will fill that as well. So we can help those patients make sure they have enough until the supply is replenished, which might be several weeks out or so. There's definitely no guarantees on the supply because everything is changing very, very quickly. The pharmacy that we're working with has a very strong supply chain because they're not a small retail pharmacy. They operate nationally and are a big wholesale purchaser of the medication. So there's no guarantees on the stock, that being said, but we have a good supply chain through this pharmacy. It's definitely not preventative. We're not recommending that anyone just take it or find it and get their hands on it and take it. There's a very small percentage of people where this might make sense because the risk and benefits are not established. And the risk and benefits are very gray, very muddy. There's no clear evidence, no clear data for this. There's some hope. There's some positive in the trials, but it's definitely not for everybody. So when patients are more severe, when they've tested positive, when the outcomes are now starting to look a little more severe, the risk-benefit equation starts to look a little bit different. So healthy patients would probably feel worse if they took this combination therapy. Doesn't make sense. And most patients that call in have a cold, flu, sinusitis, laryngitis, and they need very simple standard treatments, antibiotics, and so on. We started about a week ago. We started offering it just before President Trump made the announcement, and that's partly why we have some of the supply chain. But since the announcement, the interest has changed very dramatically, and so the supplies have become smaller, and so we've actually tightened our criteria as well. Because there is not as much to go around today as there was 5 days ago, 10 days ago. Absolutely not a drug to self-prescribe. Very few people actually need it. And given that the data is so thin, it doesn't make sense for people to be using it unless the risk and benefit is much more severe for patients that are symptomatic and have tested positive, where at that point there is no known option right now. And this is one medication that may have some potential or some hope. People are definitely hoarding the medication, and that's the reason for the shortages. And that's very concerning because the vast majority of those patients don't need it. And even if they did, they haven't spoken to a physician about, the scope of how to take it and, what to watch for and so on. So this is an experimental treatment. basically. There's no FDA-approved treatment for COVID-19. There's some early clinical trials. They show some promise. There's some anecdotal evidence that's out there as well. A lot of patients that test positive end up in the hospital, and they're treated locally, sometimes with this same combination therapy. We're seeing a lot of hospitals here in LA starting to use it. Adventists down here started using it. So we're not seeing those patients. Those patients have local care. They're monitored much more closely. They have much more complex health needs. We're trying to help patients stay out of the hospital, which is where the biggest healthcare burden is coming from. So a lot of these patients that develop significant symptoms that are not yet in the hospital, and maybe they haven't even yet been tested, right, because of the shortages, we want to try and make a difference there to keep those people from entering the hospital system, if possible, to prevent some of those shortages from deepening. There's not a lot of research, but the most recent data is the French study, and we're using the same dosing schedule that they used. And it was a very small trial. It wasn't controlled, and the data is certainly thin, but from that, the patients that took the combination therapy improved fairly dramatically within 6 days. And the French study was built on a lot of trials that were done in China prior to that. And so the Chinese trials also show some potential benefit there. But again, everything has been done very quickly because of the circumstances. And so we'd love to have, full set of clinical data, clinical trials that controlled, and those are coming. But until then, this may be something that has some potential. In terms of this medication with the hydroxychloroquine, I think it's good to have a level of skepticism because we don't have definitive data. So even amongst our physician panel, we had discussions about pros and cons and if it makes sense or not. And the general consensus is if the risk is great at this point, then even an experimental option which shows some hope or some promise might make sense for some patients, but it's certainly not something to distribute to the entire population for prevention or for people that are just scared that what's going on and they should just take it. It's definitely not for those situations. The only studies that have been done, and even those are thin, have been with patients that were very sick already. So there's no data on prevention at all, not even thin data. And so to use this medication, people really need to be evaluated by a physician. Their risk has to be evaluated. Both of these medications are FDA approved for other purposes. So physicians are able to prescribe medications off-label without any issues. The FDA has even said, Director Hahn, I believe, said that the hydroxychloroquine would be okay for compassionate use, which is a way of saying off-label, basically, meaning hasn't been proven to work, but physicians can make that judgment call themselves. There's a cluster of side effects with this and some contraindications for both of these. So all of our physicians are trained to prescribe the medication, and we're not prescribing it for patients with cardiac disease, for example, and some other conditions. So it's prescribed very responsibly. We're not giving it to patients where it's going to make them sicker or increase there's risk factors. So there's a lot of clinical trials that have started. So hopefully we'll get some data back in the next several weeks if they can accelerate it. We are prioritizing New York, California, and Washington State, especially the last week or so with the shortages. That's where, should this make a difference, it'll help the most people. So we're helping people all over the country, but we primarily are looking at New York, California, Washington, just because of the heightened crisis in those states. DocTalkGo, we've been doing telemedicine about 10 years, and we do general telemedicine. And with the crisis, we have a panel of very passionate physicians that want to pivot and make a difference and do what they can to help. And so our solution was to help people who are worried that they have COVID-19. They have symptoms that can look like it could be cold, could be the flu, could be COVID-19. So we can treat them appropriately, get them the right care. And for patients that are higher risk, potentially start to distribute a medication that remains to be seen in the next few weeks. A lot of trials are getting going. We'll get some hopefully good data very soon. But we want to be prepared to be able to offer that to patients, should that become more validated in the data. We do general medicine. Our doctors do general medicine. We have some specialists, but we're not pretending to be specialists around this process. We're trying to provide access. Our whole pivot with DocTalkGo and then creating COVID medical tests was to repurpose our network of physicians, since we have the technology, we have the distribution to be able to be part of the solution in whatever way we can, whether it's evaluating people for general telemedicine all the way through to providing some supportive care for COVID-19. So we do a 10-day course is what our supply is. The boards of pharmacy are requiring that it not be dispensed greater than a 14-day supply, generally speaking. So that's the cap that the pharmacy boards have set to try to control the supply chain, which is a great move, and we're prescribing it at a 10-day supply for that as well. So we prefer they saw their local physician, to establish primary care physician. Their doctors may not have access to a pharmacy that can fill the medication as part of the gap. And a lot of patients are trying to stay home and not move about too much. And so we can provide the whole service via telemedicine at home. Our pharmacy will mail the medication to their house. So it keeps it a little bit more quarantined. But we just want to help patients wherever they get the care is okay. We provide an option where some patients aren't able to get access, or we've helped patients who were in a ski resort recently. They were on a lockdown. They couldn't get access to care, and they were able to call us. And so we can fill a lot of gaps in the way healthcare has suddenly become a little fractured because of the quarantines and restrictions on movement. We don't do any in-person appointments. We're strictly telemedicine. And the vast majority of people that have cold and flu symptoms right now have the cold or the flu. The vast majority. Very few have COVID-19. Of those, even fewer would even qualify for the medication. It may be covered by insurance because of a lot of the emergency declarations right now. So patients may be able to submit a claim to their insurance. We don't bill insurance, but the patient should be able to submit a claim for this. All indications point to the fact that we're not close to the peak yet. So, it's sobering to think and say that, but it seems like it's definitely going to get worse. We're hoping to reduce that curve by keeping people out of the healthcare system that don't need to be there. And hopefully we're crossing our fingers in the next few weeks, these trials that have started on hydroxychloroquine show some positive outcomes, and the supply chain will start to get replenished the next several weeks. The manufacturers are ramping up production of the medication as well. So if the tests are positive, there'll be a good supply in the next several weeks where more patients will be able to get it. So that's our hope. But until then, it's an experimental treatment. There's very thin evidence, but there's certainly some hope and actually showing some positive results in some early trials.